ability to do the work that is needed to help you repair. A lot of times we're being convinced that surgery or knee replacement or some other malady of surgical nature will relieve some of the pain. But in most cases, you end up taking pain meds, which is creating an epidemic in our country. So what's happening is there's a wave of highly skilled, very knowledgeable doctors who are steeped in biologics, pain, and other areas of repair, spine surgeons, etc. They are all moving away from the need to do surgical treatments. The cost is too high. The end result for patients is not necessarily the results they desire. If anyone's ever had their spine fused, when that occurs, it certainly changes the movement and your pain threshold goes up and you're not quite what you once were. So today's presentation will provide you some clear view of what your body's capable of, what kind of doctor you need to see that will provide that for you. And one of the exciting things that I'm appreciating with Dr. Childers is his background. He is a significant mind, and I think as you guys listen to him do his presentation, you will find that the depth of his understanding and his knowledge about stem cells and regenerative medicine he'll present it in a way that's easy to understand, but he will give you the medical science that is behind it. As you've seen here on this board, these are the typical areas people are trying to get addressed, and whereas the normal pattern is let's do surgery on it, you may not even be at that place, and so regenerative medicine will provide an alternative to that. What I will also say about Dr. Childers is I'm part of an organization called Boston BioLife, and Boston BioLife trains somewhere in the neighborhood of 50 to 70 doctors every other month from all backgrounds, using cadavers and taking them through the science. Doctor has gone through that course. It is quite rigorous. Additionally, they have an advanced course, and he certainly has been able to master that as well. So you're getting one of the best in your town, actually one of the best in the East Coast. So you should feel proud to have someone like him here to look after what your concerns are. So all that being said, I am going to invite Dr. Childers to come up and do his presentation.
Thank you very much, Quentin. Again, I'm Dr. Henry Childers. I'm going to bring this back to the beginning. Good place to start. Welcome. This is about regenerative medicine, as it was indicated. Your body was designed, evolved to repair damage. And your body was designed and evolved to remodel and replace tissue as we get older. Your bones are always in the process of regenerating and other things. When you have an injury, we have mechanisms that turn on, and they have for the millions of years, to repair it without any conscious effort. If you break a leg, what happens? You know, you don't think about it other than the pain. But over the course of the 14 weeks, you have cell biology working to go in as an inflammatory effect, and basically your nervous system, your endocrine system, and your immune system, and other systems we may not even know about now. They assess the damage, they stop the continuation or the bleeding, and then over the course of 14 weeks or so, you're repairing the damage until it's completely fixed, and then you downregulate. This is how we work. It's a great system. If we can utilize that to stay healthy and treat disease, in my opinion, and most people's opinion, it's much better than having a prescription for a pharmaceutical drug that you've never seen before, or maybe an operation. Operations are good sometime. I'm a cardiothoracic surgeon. I used to operate. I like to operate. It's good sometime. It's not good all the time. The same with replacements of joints and knees and everything else. So really what we want to talk about is what are your options to have biologics work to treat your disease? And this is all under the moniker of regenerative therapy. And so what is regenerative therapy? Well, with this, what we're trying to do is, unlike a lot of other options for treatment, we're treating root cause. You can either treat symptoms or you can treat root cause. A lot of, if you have knee pain or something, there's medication you can take. You can take that Rusticome or that Synvis stuff, and I don't know really of anybody where it's worked. And I don't know why you would expect it to work, because this is a pharmaceutical that we're using oftentimes to try to help, but it helps by diminishing symptoms, not necessarily correcting the problem. With regenerative therapy, what we're doing is we're taking cells, your cells, processing them and putting them back in and concentrating them in areas so it can do what they were designed to do, and that is help to rebuild, remodel, regenerate. Again, as I mentioned, there are many different aspects of regenerative therapy, and it ranges from simple stimulation of cells and release of growth factors all the way to use of stem cells. And what we're going to mostly talk about today are the stem cells. These are the body's normal regenerative cells. There are two major functions of stem cells. They divide to make more, and they differentiate to adopt the characteristics of other tissues. And I have a cartoon I'm going to show you about the evolution of cells from sperm and egg all the way through to an organism. And by showing you that cartoon, you're going to understand what a stem cell is and what a stem cell does. But remember, it does more than two things, but the two main things are they divide and they can differentiate into other cells. So if you have, as we remodel bone, for example, which we do throughout our life, the old bone cells basically die. They have programmed cell death. We get rid of them and new cells come in and replace them. That's stimulated by stem cells. One of the things, this is a slide from probably the leader in stem cell research, Dr. Kaplan, and what he discovered was that stem cell, and this MSC is for mesenchymal stem cell. These are the cells that are primarily used for bone and muscle and cartilage. We actually now are starting to call them pericytes because we know all of these cells lie on top of all blood vessels. This is a stem cell. These are stem cells. These aren't in red, but these down here are stem cells. And you can see they're coating this. This is a capillary. This is a blood cell. This is a blood vessel. All blood vessels are coated with stem cells, we found out. And that's important because the circulatory system has become the highway for the delivery of stem cells. Also, all stem cells have a rich blood source. Also, stem cells migrate to damaged areas. And how are you going to find out where there's a damaged area? You need to have an elaboration of some biochemical that's released and becomes systemic, meaning circulatory system, to alert these other cells that there's an issue, number one, and that they need to migrate to the site of injury. This is the slide I was telling you about, and this basically shows you what a stem cell is. Again, this is mesenchymal stem cells. There are various kinds, and this is the one we're going to talk about today. They can differentiate, meaning they can adopt the characteristic of all the cells in the body. So stem cells, they're all the same. They have no role or function until they're given an assignment. Once they're given the assignment, then it becomes, this is cartilage, chondrocytes are cartilage cells, muscle, fibroblasts, marrow, you can look around the clock. All of our live cells can derive from stem cells and originally did derive from stem cells. This is a little cartoon that I like because it shows, again, this is, at conception you have a sperm and an egg and you have one cell, okay? That divides into 2, and that divides into 4, and that divides into 8. And then you get a big bundle of cells here. They're all exactly the same, okay? We go from this, a whole bunch of cells which are exactly the same, to this. And this guy's got brain, he's got a heart, he's got muscle and hair and skin and everything else. At some point, these cells, which are all exactly the same, differentiate. They adopt the characteristics of all of the other tissues in the body. this is, in this cartoon, what they did is they plated these cells and then they induced them, as happens naturally. And these cells, which were all identical, differentiated into, these are intestinal cells, this is pancreatic islet cells, muscle, bone, nerves, et cetera, et cetera. That's what stem cells do. That's how in the beginning we've gone from a bunch of cells to a human being, but that's how we remodel as we get older. Not going to spend time on this. All cells have different surface markers. These are transcribed from the DNA, and the surface markers will tell us what kind of cell it is, and they have particular function. I'm only putting this up there because we measure, when we have stem cells, what we like to do is measure the different, it's called CD markers. We like to measure the CD markers because we know stem cells are characteristic of having certain markers, CD70, CD90. They don't have others like CD34. And this is very important because if we're going to be doing any kind of stem cell therapy, you want to make sure the cells we end up with are the cells that we're looking for. And so we go through a process of separating, and we can identify those cells. So what do stem cells do? Okay. They can migrate, as I mentioned, because they're all connected to the highway, the circulatory system. They can migrate to the areas of damage or inflammation. And again, that's because damaged tissue elaborates a biochemical. It's like raising a flag, and it says, you know, we're injured over here. So your body does not repair everything all the time. It repairs things when it's damaged. How does it know it's damaged? How do you know you have an injury someplace? Because they give off a chemical response. And that chemical response, which is systemic, is received by the immune system and all kinds of cells, including stem cells. Then you migrate to that area of injury. That broken leg we used as an example. No one here is, I don't think, fixing a broken leg right now, but if you broke it, all of a sudden you have a big response concentrating on that area. It has to be stimulated. You have to turn on that mechanism in order to do that. And that's the inflammatory response, which stimulates the stem cell function. As we said before, they differentiate, so all of the stem cells are exactly the same until we put it into an environment with injured tissue, and then those injured tissues, or then the stem cells will adopt the anatomy, the configuration of the injured tissue. What we now know also is that all stem cells have the ability, when they go into an injured area or when we transplant them into, let's just say, a knee, for example, not only do the stem cells differentiate and divide, but they release biochemicals, growth factors and cytokines and other components to turn on the associated tissue in the area. So again, if it's a knee, you're stimulating the subchondral bone and the periosteum and the cartilage and the muscle and everything else because you are releasing biochemical response to correct injury. This is all part of the injury pathway. So we know that they elaborate, and this is why if we take a bunch of stem cells and we put it into a knee, not only are we dividing and we're differentiating into some of those tissues, we're stimulating the rest of the surrounding tissue to recover. There's something else in this. I was told we get too complicated with it, but it's called exosomes. Exosomes are genetic material released, and I have a slide to show you about this. They release from stem cells. And the exosomes, they have genetic material which it simulates what a stem cell does. That genetic material gets absorbed into the surrounding tissues that are injured. And now you're taking the genetic material from the stem cell and putting it into these other cells. So they're mimicking what a stem cell does. And the exosomes are probably the hottest area in regenerative medicine right now, what they can do. It's doing what a stem cell does, but we're taking the genetic package and putting it into the cells in the surrounding area. This slide I put up here because it represents, this is a mouse. First of all, Dr. Diego Carrera and Dr. Alan Kaplan, I talked about him before, but Dr. Carrera is in Florida, and he's probably, as far as a cell biologist, one of the leaders in stem cell research. And he's coming up with a lot of the literature of not only the results, but how these things work. They collaborated and they took a mouse and they irradiated the knee of this mouse to create an injury. This mouse was basically a normal mouse. Created injury. Then they took stem cells from this mouse and they labeled them with something that we can pick up with an X-ray. and they injected it into the mouse. The reason why is because we wanted to see if stem cells actually did migrate to the site of injury. So after an hour, you don't really see much. 2 days, you can start to see some migration, 7 days. By 21 days, and again, this is a long-term process. It's biologic, so it doesn't happen overnight. It's not like a prescription. You take it and you feel better in an hour. This is a long-term process. This is how our body works. After 21 days, you can see this is all concentrated right on that damaged knee. No place else. It hones in to the damaged area because the damaged tissue elaborates all of those inflammatory markers. This is kind of a blow-up picture, but you can see how concentrated it is exactly on the place where they have the injury. So the types of stem cells or regenerative medicine that we have available these days is autologous and there's allogenic. Autologous is yours. We'll take your stem cells. There are two major sources we'll go over, bone marrow and fat. We take your cells, we concentrate them, we clean them, we activate them, we count them. Very importantly, we want to know the number and we want to make sure there's a viability there. So we expect to have 100 million cells and we expect there to be about 97% viability. That's when we take yours. The other alternative is the allogenic. These are from donors. There's a whole couple companies that have an industry, and women who have consented, they're going to have a cesarean section, they consent, they're tested, they go through rigorous protocol, and at their planned cesarean section, the placenta is taken, and you can separate out different regenerative components from those. So if you've ever heard you can get amniotic fluid to, put in a Wharton's jelly, these are some of the terms. These are from a bank. It's almost from a tissue bank. But these are all well screened. There's no disease. They're safe. They're very expensive. But it is an option for regenerative therapy. Of the autologous, we get the most yield out of adipose-derived tissue. And that's a mini liposuction, and to remove it, it probably takes about 40 minutes to do. You're awake, it's not painful. We put a little wheel of anesthesia on each side where we go in for the mini liposuction, and everyone says, can you take out more? And we take out a fair amount, but we're not doing any shaping or contouring or anything. But we take those cells and then we take them into the sterile environment, into the lab, and we process those. They give us predominantly mesenchymal, and this is why we like adipose tissue, because the mesenchymal stem cells are the ones that are really working on bone and muscle and cartilage and all of that. It also gives us a much higher yield than anything else we can do for stem cells. Down here, this is platelet-rich plasma, and a lot of people have heard about that, PRP. What PRP is, we draw blood and we separate the blood out into the different components. We know that the platelets and the monocytes, part of the white blood cells, the immune system, have the ability to elaborate growth factors and cytokines and fibrin and other mechanisms of repair. So this is something we've used also. You don't have live stem cells. It's not as good as stem cells, clearly not as good as stem cell, but it's very advantageous for the treatment of many different diseases. And again, depending on what people are talking about, depending on what we're going to do and what we're going to treat, we have a combination of different things, different therapies that we use to treat those. I'm a cardiothoracic surgeon. I've been using PRP in cardiac surgery since, probably for 15 years or something. So, a lot of these things, this has actually been around for over 100 years. This is newer technology. It's been around, for decades, but it is a newer technology. But certainly, platelet-rich plasma has been proven over a century to be very viable. This is a little cartoon. I apologize, the top got cut off, but basically this is just showing you how we do the adipose-derived stem cell. Mini lipo, this is fat, okay, this is skin, this is muscle. We take the fat cells, and here's the fat, and you can see every fat cell has a capillary, at least a capillary connected to it. That's the blood supply. And on the blood supply, you have all these stem cells. So we take out a collection of this, put it into a conical tube, we separate it in different ways. So we end up with, this is like the oily part of the fat, and this is just big fat cells. And this is what we call just the infranate. It's just the saline wash. And down at the bottom is the stromal SVF, stromal vascular fraction. That pellet is comprised of stem cells and fibroblasts and all of those things which are responsible for a regenerative response. The alternative for bone marrow from you, if we're going to take yours, for stem cells, is bone marrow. And this is, a lot of people are turned off by it because they think it's going to hurt and you're drilling into the bone. It's pretty painless. We go into the back of the pelvis. It's a quick procedure, and it's giving us stem cells which are slightly different. There's not as many mesenchymal stem cells, so typically we don't use this for orthopedic issues. But these have a lot of hematopoietic stem cells, and it has a lot of what we call T regulatory cells, which have been shown to be dramatic in its influence on a lot of neurodegenerative diseases. And if we're not going to talk about IV stem cells for all the other things. We're really talking about orthopedics mainly. But for all of the work that is done with IV, bone marrow often is, depending on what we're treating, is going to be a better choice than the adipose-derived. And then the allograft is, as I said, full-term C-section delivery donor mothers who were screened, so this is all safe. It's kind of like if you go to a blood bank, you used to worry about getting disease. We screen them now, so it's safe. These are safe. I don't use them that much. People want to use their own for good reason. Number one, if you use your own, you get a lot more. These become pretty expensive, but for some reason, people want to use allographic material, and that's great too. I don't know how much you know about stem cells if you've been to other seminars or you've heard things, but from this tissue, we get 3 different types of material for regeneration. One is called amniotic fluid. That is actually fluid. In it, it has growth factors, and it has cytokines, and it's great, and it has all this powerful stuff which turns cells on. It does not have stem cells. I've heard people present and they talk about amniotic fluid and it has stem cells. It does not have stem cells. It's never had stem cells. It doesn't. If you hear someone claim it, call them on it, because there aren't stem cells in there, okay, period. No matter how much you're trying to be convinced. Wharton's jelly is a thick, viscous fluid that is around the umbilical vessel, okay? That is like the amniotic fluid on steroids. It has a lot more fiber in it, has a lot more other characteristics, but it has more growth factors and everything else, and it's really an amped up version of the amniotic fluid. It doesn't have live cells in there either. And again, be careful, because a lot of people are talking about you buy these things and you're getting stem cells. It's not. The umbilical cord blood has stem cells. They're young and they're very effective. They're very good. People wonder about, well, they're not my cells, am I going to have a reaction? And you don't, because stem cells, they're so what we call naive. They don't have all the characteristics to reject yet, because they're undifferentiated. So this is very safe, and the stem cells in there are very good because they're very young. The problem is, for a little vial, it's lots and lots and lots of money. So if you want to get the number of cells that we're getting from adipose-derived, it's I don't know, $20,000, $30,000 is going to be just for that alone. And that's why I try to steer away from it as much as possible. Okay, so, and again, what we're talking about here is orthopedic. So neck, back, shoulder, hip, you could imagine, I'm sure you all knew all of the things we can address. And this goes further to have a little bit more elaborate definition of the areas of treating. For stem cells, the best biologic treatment we have for all of these things are stem cells. That being said, on this list, there's tennis elbow. If you came in and you had tennis elbow, I would not recommend stem cells. Would it work better than everything else? Yeah. But you don't need it. It's kind of a nuclear bomb for a simple problem. There are other, cheaper, easier things you can do for tendinopathy. If it's a knee or a hip or another condition like that, which is arthritic, of course stem cells are the choice. But we put these slides up, and I put them up a little tentatively, because if you came in with a tendinopathy, I wouldn't tell you to spend the money on stem cells. We can get there doing other regenerative things, because we do a whole array including prolozone and the PRP and other things we do to treat root cause, not the symptoms. It's not a steroid injection, which does damage and it hopefully gets rid of the pain, but it's not going to solve anything. We have many different regenerative options we can do to treat all aspects of disease. This is why it's so important to come with all your information and talk to a doctor and find out for you what's the best thing, because stem cells will do all of this, but I wouldn't recommend it for all of this. For the big things, yes. For the simpler things, no. These are exosomes. I'm not going to spend much time on it. I was told it gets too complicated. Basically, these are little lipid fat vacuoles released from stem cells, and in it they contain all kind of good stuff, growth factors, etc., but they contain genetic material. Because these are lipid vacuoles, they can easily be absorbed into other cells in the area of damage. When they get absorbed, the genetic material is now turning on expression in those cells to do what the stem cells are going to do. So what it really is, let's just say you're getting 10 stem cells, but you're getting the exosomes too, and the exosomes are having an influence on the surrounding tissue to act like stem cells. So it's an amplification effect. This is just a cartoon showing this is a stem cell here and all these little things. This is all the good stuff in genetic material and growth factors. And you can see how it just kind of fuses because it's lipid. So it fuses with a cell wall and it just basically regurgitates out all these little packets. And these things are just absorbed into the other cell. This is how an exosome works. It really has become a centerpiece for a lot of the tissue biologic magazines now because this topic is so hot. So we're getting more and more information on exosomes. Who needs exosomes? Depends on your condition. Everyone's different. Stem cells are appropriate for some people. Some people, PRP. Some people, prolozone. Some people, we're going to do the stem cells with the exosomes, but not everybody. It depends on what we're dealing with. So it really is a customized treatment for every particular patient. So what do you expect? Well, will it hurt? We don't sedate people because no one's needed sedation. I've had it done. I got into I'm a cardiac surgeon. I got into all of this because of my sports-related injuries, and my background is in biochemistry and molecular biology and my research, and this is along the lines of all of that. When I first got treated for my injuries, I was just kind of blown away at the effect that I started studying, and I realized it's basic biochemistry. That's how I got involved with this. The more I did it, the more I liked it. The results spoke for themselves, and I've directed my practice into these sort of cell biologic therapies more than surgery. And I don't really write prescriptions because I think there's a way around it. Sometimes they're important, but for the most part, I like to avoid that as much as possible. So I've had it done. It doesn't hurt. It's a vibratory sense. It takes about 20 minutes to remove the cells. After we do that, you're going to wait until they're processed, and then we inject them into a knee. Does that hurt? If you've ever had a knee injection, steroids, Synvisc, or anything, it's a needle. Goes into the knee, and it's not the biggest thing, but it's, you got to get it in there, okay? You will be awake. Again, we don't sedate. There's no reason to sedate. I want people awake. I want people to hear what, we have conversation as we're going. I want to know if it's tender or anything else, and we accommodate. And how long does it take? Here we say 2 hours. It's usually 2 hours, maybe a little bit more. The vast majority of the time is patients waiting. We have TV, we have comfortable chairs, but you're going to wait while we process the cells. Once we have the cells, then we're going to implant that into a knee, again, for example. Then you come back and we do that procedure. That takes us about 10 minutes. The stem cell retrieval takes probably about 40 minutes. The vast majority of the time is me under a sterile hood preparing tissue. So, again, why would you be interested in this? Do you want an operation? Do you want to be taking pain medication? This is no drugs. It is no surgery. The recovery time is, we tell people that what we want you to do for about 4 to 6 weeks is not traumatize that. Normal activity. If you're a runner, don't run. You have an injury. Why are you going to run? Right? You have an injury. Let it heal. After that time, we advise getting back into something, or physical therapy, or whatever your needs are, to start stimulating that joint and start getting the motion back. Now, the research has shown that these cells continue to proliferate and work past a year and a half now. Now we're showing up to 2 years because these are live cells. They will continue to work for, and we don't know how long, but we know it's over a year. We really start seeing some differences at about 6 months. But again, remember, this is biologic. It takes a long time. If you break a leg, it's not going to be fixed in a week. It's going to take 14 weeks or whatever it is, and then after that, you're still kind of healing. It takes a while, but anything biologic that's going to heal takes time. We know at 6 months we start really getting, a good slope of recovery, and then, like I said, up to 2 years later, we're continuing to see the progress, and that's the long-term relief. So again, since early 1900s, they've been doing various things like this, and there's documented benefits. And what about success rate? And I think one of the most important things for everyone to take out of this is you need a proper expectation of where you are and where you're going to get to. Now, stem cells have, Lindsey Vonn, skier, most famous American female skier, she had stem cells for her knee. All kind of football players and professional athletes, they're doing this, and they're getting back out in a couple months and performing on a very high level. They are also very young. Genetically, they're probably, they heal better than me. That's why they do what they do. And there are other reasons why they do so well. Now, if you're morbidly obese and you have severe disease and you've had it for 40 years and you're basically can hardly walk, it's going to be more difficult for you to get to where a healthier person is. And I'm not trying to discourage anybody, but I'm saying you need to have a proper understanding and expectation of what this will do for you. Again, I've been to lectures and they say you do this and you're going to be 14 again. It doesn't work like that. The objective is, for most people, we would like to see them free of disease and discomfort. And that's what we see. Everyone will benefit. But the question, because we know it's anti-inflammatory, we know it's helping with the repair mechanism, etc. But this is why it's so important to have a proper consultation. Depending on the degree of your disease, your general health, your genetics, and other things, everyone may be a little bit different. We haven't had anybody who has not had results, but again, it's going to vary depending on what we're dealing with. Depending on your disease. And again, this is why we talk about a consultation. We used to start off by doing stem cells. We harvest stem cells and we inject them into your knee, and that's good, and you go away. And we found a couple things. Number one, and this is why we change our practice, and this is what the research shows us. We start off with a preconditioning of, I always use a knee as an example, but the preconditioning of a knee. We're going to use PRP that I went over and inject it into that knee with prolozone. What that does is it starts a repair mechanism, and it creates an environment which is going to be amenable for transplantation. So the inflammation, which is the pain, the inflammation will diminish, and we're making a good fertile ground